Okay, so introduce Dr. Rachel Howard from University of Reading, who's going to talk to us about errors and the context of errors for prescribing.
Okay, excuse the glass of water, I'm still getting over a cold. So yeah, a little bit of background, not quite as extensive as Steve's, I have to say, but I am a pharmacist. I started off working in hospital. I got hijacked by someone called Professor Avery in Nottingham to go and do research, and I haven't looked back since, really. I carried on doing some work in hospital whilst doing my PhD on preventable drug-related admissions to hospital. I then moved into doing some practice, general practice work alongside my PhD, because I thought, why am I still working in hospital when all of my research is about primary care? And then when I finished my PhD, I started my lectureship at the University of Reading, where I've carried on doing research into medication errors. So what I'm going to talk about today is largely about 3 studies, a little bit about my work on preventable drug-related admissions, quite a lot on a study that we're just finishing writing the final report for the GMC on prescribing errors in general practice, and I'll touch a little bit on something called the PINSA trial, which used the sort of IT within general practice and pharmacists in general practice to try and reduce the number of patients affected by hazardous prescribing. Okay. So what am I going to do quickly? I'm going to run through a bit on the incidence of error, a bit about the complexity of medicines management in general practice. Although Steve Freeborn says it's terribly simple in general practice, it's still a very complex process. I'm going to talk a bit about the underlying causes of those errors, so why they happen, and then a bit about using people and policies and computers as defences within general practice, and then, as I said, touching on the PINSA trial at the end there. So, what have we found in our GMC-funded study? We found that prescribing errors occur in about 4% of prescriptions, okay? And monitoring errors in general practice, monitoring is a very important feature of prescribing, so we've included that in our study. And they're in about 0.9% of prescriptions. Now, the definition that we use for prescribing errors is to say that these are clinically significant errors, not just the suboptimal prescribing. If you include suboptimal prescribing as well, that's an additional 7%. Okay. So this is a big study across 15 practices. Lots and lots and lots of prescriptions have been looked at. And if we compare this to the work that was done up in Manchester by Tim Dornan and his colleagues, then 8.9% of the medication orders contained errors in the hospitals, so it's a big contrast in the area of care, and about 5.9% of consultants' prescription orders contained errors. Okay, so that's similar to the error rate in general practice, if you look at those very experienced prescribers. Now, in terms of the complexity of medicines management in general practice, this is a very pretty diagram that I've developed as I've been going through the data for the GMC prescribing errors study. And I don't expect anyone to read this in detail, but it's just to highlight the number of different stages, the different processes involved in reaching each of those, and how you kind of flow through all of those stages. And that gives an idea of the complexity of preventing errors, because each of those stages is an opportunity for error and therefore needs to have a defence associated with it.
I told you it was simple, Rachel.
Yeah, absolutely. I can imagine in hospital there's quite a few more boxes and circles and things, but it's not quite the same as think, write, give. So the work that I did in my PhD was all about the underlying causes of preventable drug-related admissions. So going out, talking to GPs, patients, community pharmacists about why had someone ended up in hospital with a preventable drug-related admission. And there were a few things that really came out as common themes. And they were time and workload pressures. So people feeling under a great deal of pressure to get stuff done quickly, and the same is seen in the hospital studies as well. And knowledge of patients. Being able to get the information about the patients in a timely fashion, okay, so that you can make good prescribing decisions. Knowledge about the drugs. Being able to get the information about the drugs. So is it to hand? Do you know about it? Is it a familiar drug or is it something brand new? Okay. And then communication problems. And that's communication problems between prescribers, between primary care and secondary care, between prescribers and patients, between prescribers and pharmacists, communication problems all over the place, okay? And they all contribute towards errors. And as you can see, there's a whole lot more going on in that system as well, but those were the sort of key features. And the reason I've highlighted those is because those are some of the things that we tried to address within the PINSA trial that I'm going to touch on at the end. So the GMC-funded study that I've just been doing was looking at the underlying causes of prescribing errors in general practice. And what we found was that we could map this onto Reason's model of organisational accidents, which talks about the error-producing conditions which lead to errors, okay? And he categorises things into different sections. He talks about prescribers, he talks about tasks, teams, he talks about the environment that you work in. Now, I can't present the full results of that here because we're still in the process of writing it all up. The final report goes in on Monday, and as with all of these things, it's a little bit lastminute.com, okay? But big features, and this isn't everything, but big features that came out with the prescribers, things around their therapeutic training. These GPs were saying that they basically didn't get therapeutic training, that the VTS scheme did not give them that grounding, okay? And that some of these GPs felt that that therefore contributed to errors that they may make. Drug knowledge and experience. The GPs really like to kind of stay within the drugs that were familiar to them. So there may not be a formal overall formulary, but the GPs will have that sort of comfort zone of what they prescribe with. And when it goes outside of that comfort zone, then things start to get a bit more tricky. And knowledge of the patient was a real issue in walk-in centres, okay? So walk-in centres, unregistered patients turn up with hopefully minor ailments, but not always, according to the GPs, and you have to make prescribing decisions. And the GPs that worked in the walk-in centre, or centres, I think there may have been 2 of them, were deeply unhappy with the safety of prescribing in that setting because they did not know anything about those patients. And their feeling was that the summary care record, when it does finally come online, would be a huge change for the safety of the system they worked in. There's also another issue around the knowledge of the patient in terms of complacency. If you've known a patient for many, many years, then there may be a tendency to make assumptions about the problems that they experience or the conditions that they have and to not go back and check in the records. And again, it was felt that in some cases this contributed to errors occurring. Risk perception is an interesting one. There was one GP who, when asked at what point would he intervene on someone's low blood pressure, his response was, when I'm falling over, or not when he's falling over, when the patient's falling over. And personally, I think that's a little bit late. If they've reached the point where they're falling over, then they're already injuring themselves. Now, he may have been being flippant, but this is a GMC-funded study, and you would think that would perhaps rein you in slightly on what you say, and I think it just raises questions over at least this GP's risk perception in terms of prescribing and how he monitors his patients and responds to changes in their test results. There's also issues around the physical and emotional health of the GPs, how stressed they are if they're feeling ill. All of the things that you can kind of see would contribute to making errors. And the patients, they're individuals and they're people, and they can also contribute to errors, unfortunately. The complexity of their cases. The patients where it's really important that they get a good medication review are the ones who are on lots of drugs. And those are often the patients who will turn up, have their long chat about how awful everything is, and at the last second in their 10-minute consultation that's already overrun into 20 minutes, half an hour, they all sit there and say, by the way, doctor, I need my prescriptions renewing. And this is the point where they should be having their medication review, and the GP may have 30 seconds to quickly flick down the list of drugs, renew them, otherwise that patient can't get their prescriptions. So there was a big issue around the most complex patients under the current systems may not be getting the best medication reviews they can. There's also the perceived attitudes of patients around the importance of the medication reviews and for turning up for monitoring. So there'll be patients who just will not turn up unless you change their prescription to not being on repeat and you force them to come into the surgery. And at least you have that system available. But there are difficulties there because you don't have the patient in front of you captive to jab them with needles. And there's also language barriers. As one GP talked about having Polish patients who couldn't speak any English, but he felt that one of the bonuses with his community pharmacist was that he knew that his community pharmacist could speak Polish. So he would sometimes send his patients over there, having phoned the pharmacist in advance to give them instructions of what to say to the patient. And then finally, the teams of people that are working in general practice. There are issues around communication amongst those teams, between the nurses and the GPs, between primary care and secondary care as well. And there's sort of blurred responsibilities. Who is responsible for doing the monitoring? Who is responsible for that medication review? Who is responsible for entering the results? Who's responsible for reviewing those results? Trying to get clear boundaries on that and making sure it happens is really important. And the correspondence from secondary care, which can be good, but it can also be absolutely lamentable. And some of the GPs talk about having huge long paragraphs, sort of 2-page letters of information, of story, with no summary anywhere. And the GP saying, I've got 30 seconds to look at this letter, decide what's important and make the changes on the computer. And I'm having to sit here and read 2 sides of A4. That's about 800 words. That's an awful lot of information to process. And that's why sometimes those changes get missed and create errors. And there's also issues around how that information is transmitted. Is it electronically transmitted or is it paper transmitted? Is it therefore delayed in the post? Is there a delay in getting it typed up? Has the patient come in for their next lot of medication before you've ever had that information? So if we think about computer factors associated with errors, because we think about computers as being this big defense, but if we think about those interaction alerts, which are supposed to be one of the big defenses, there are too many of them. The GPs get alert fatigue. They just switch them off. So the better systems have graded alerts so that they can decide which levels of alert they will switch off. But if they're not graded, they'll just switch off the whole lot. Not every GP will, and the interaction alerts are considered to be really useful for the GP registrars who will pay attention to them because they're used to having a pharmacist telling them that things have gone wrong, and they suddenly lose that in general practice. But a lot of those alerts just tell you there's a problem. They don't tell you what that problem is, what the sort of percentage risks may be. They don't tell you how to manage that risk. And that's the sort of information. One of the GPs said, we just need a little paragraph of summary of what's going on so that they can make a judgment about whether or not that's important without having to go to another textbook, which is unlikely to happen in a 10-minute appointment. Picking lists. Picking lists are dangerous because if they're an alphabetical list of names, you can get some very similar ones sitting next to each other. And one of the classic examples is penicillin and penicillamine. And penicillamine comes first, and that's the big risk, because you don't want to pick penicillamine if you meant penicillin for very obvious reasons. Okay, so I'll talk a bit more in the defences section about what you can do to make that safer. Formularies, like I said, formularies are brilliant. They're really useful. Formularies are great unless they're not embedded into your prescribing software. Because if they're not embedded in there, you don't tend to go and look at them because that means changing screens on the computer. And that's something that most GPs don't want to have to do. Because there are risks when you start changing screens that you end up back in the wrong place in the medical record as well. Dispensing machines, and I won't talk much about dispensing, but there was one practice that was a dispensing practice, and there are issues around those dispensing machines in terms of manually entering the products when they first enter that dispensary, not being able to recognise the quantity of packs, so you can give out the wrong amount very easily, and no recognition of the standard abbreviations. And I think this is something we can learn for the electronic transfer of prescriptions, perhaps, because the system that they had electronically transferred the prescription from the GP's computer over to the dispensary, but the dispensing computer didn't understand a lot of the abbreviations. So you might put 1OM, and if it was an omeprazole that it was on, your label would come out saying 1OM. That's not amazingly useful for the majority of patients. And in general, GPs did not like viewing multiple screens. They did not like having to switch between screens. And they did not like it if data wasn't coded properly. Because if it's not coded, it means you don't find it. It doesn't produce any alerts for you. Particular issue with allergies and the importance of training people when they're summarising the notes to make sure it's all been properly coded. So, into the defences. What can people do to make prescribing safer? So one GP had this brilliant system. When he was issuing a prescription, he would print it out and he would read it out loud to the patient. And his argument for doing this for 99% of his prescriptions was that, one, he could do a mental check that what it said on paper was what it was supposed to say on the paper, that he hadn't accidentally printed out a prescription for someone else, he hadn't keyed in the wrong thing. But also, he could then counsel the patient about what was on that prescription and confirm with them. And this is only one GP did this, and the rest of the GPs that were in this focus group were all kind of like, wow, that's amazing, why haven't we done that? So it's very simple things can make life a lot safer. Postgraduate training was considered to be important, and making sure that your clinical knowledge was kept up to date. And, as I said, prescribing familiar medicines, trying to have your own formulary or the practice's formulary that you stuck to. And attending to interaction alerts, not just passing them by and ignoring them. But one of the key things was checking the BNF. Okay? One of the things that made that even better was if the BNF was electronic and linked into the prescribing system. So all they had to do was click and you're into the BNF. Repeat prescribing is a big thing in general practice. And one of the things that the GP said was only putting patients onto repeat prescriptions if they are stable. Okay? So making sure that they're not needing changes in those prescriptions. And signing those prescriptions in small batches. Because otherwise, if you have a pile this high, you sit there, you don't read them. So in one surgery, the receptionists were encouraged to bring the prescriptions in small batches so that the GPs could focus on each individual prescription. And there are other ways of dealing with it in all the different surgeries. Monitoring the patients. One of the GPs said, review the patients 2 to 6 weeks after starting a new medicine. In fact, quite a few of the GPs had a policy of pulling patients back in for monitoring and checking on them before they put them onto repeat prescriptions. And one GP felt that titrating doses was something that doctors had forgotten to do. And he has a lot to say on the matter, but I'll leave it there. Managing the specialist correspondence, so those letters that come in from secondary care, a big thing was about clarifying what consultants were saying if it was outside a GP's comfort zone. And not all GPs would do that. Some of them would say, well, consultants recommended it, he's the expert in this area, I'll do it, it's outside the BNF recommended doses, but it's what he says. But remember, that error rate for consultants is 5.9%. So you cannot assume that what the consultant has written down is what they meant to write down. And supporting medicines management, community pharmacists and practice pharmacists. The role is very limited at the moment. And again, I'll talk about the Pincer trial and how that can be made better. But the information resources for community pharmacists mean that that role is very limited because they can't make those clinical judgments that you can make in a hospital setting. So what can practices do at a policy level? What can they implement that will make things better? Well, they can make easy access to information resources. So making sure that you have an electronic BNF, or that you have at least a paper BNF in each room, that you have other information resources available. Adopting a practice formulary so that your GPs have got something to work to that keeps them in their comfort zone. And with high-risk medicines, so the methotrexate and the warfarin, prescribing just one single strength so that you don't get mix-ups. That was felt to have been a big change with the change for methotrexate, and is also done in some localities for warfarin as well. In terms of repeat prescribing, one thing that was fairly common was not accepting verbal requests for repeat prescriptions, because there is just too much possibility of getting that wrong. And having dedicated trained staff to manage the repeat prescriptions, but not just one person, because if that one person goes on holiday or goes off sick, the whole system goes completely to pot. You have to have some backup in there as well, of somebody else who knows what to do. And warfarin is a huge issue in general practice, because it's not monitored in general practice, it's monitored in secondary care largely, in the anticoagulation clinics. And so there has to be a way of getting that information on what the INR results are back to general practice, who take the responsibility for prescribing the warfarin. And that system doesn't really exist. So in one practice, they had a system of always asking to see the yellow book before they would issue a repeat prescription. In terms of monitoring patients, making sure you have face-to-face medication reviews. There was one practice where the GP would preemptively search, find out which patients were coming up for needing their repeats renewing, and he would look down the list. He'd go, yes, have they had their monitoring? Okay, we'll order some tests, renew it all. That misses out on what patient may be experiencing, whether they're adhering to their medication, all sorts of things. That face-to-face medication review, or at least a chat on the telephone, is hugely important. Managing that specialist correspondence, there are big issues around the format of letters coming in from the hospitals, making sure there is some sort of summary in there telling the GPs what the important information is, and that goes at the top of the letter, not at the bottom, at the end of all of that story. And GP surgeries making sure they update their records within, as a minimum, 48 hours of receiving that letter. And possibly easier in general practice than it is in hospitals, but to have an open, blame-free culture. They're much smaller environments that seem to be pretty across the board, that the general practices we interviewed were all very happy to talk to each other, to talk about the errors that occurred, but they weren't very happy to communicate that outside of the general practices. So there's a need to try and make that cluster-wide so that you can learn from the other practices. So computers. There is a load that computers can do to make prescribing safer. You can read code the allergies so that they come up as allergy alerts. You can link to those medicines information resources like the eBNF from within the prescribing system, so it's a simple click of a button to get to it. You can have the summary care record so that you've got easy access to a summary of someone's medical record if you've never seen them before. You can embed the formulary into your prescribing system. So that means that you force people to choose the drugs in your formulary, or you make it much more likely by putting them much higher up the priority list. And you can separate out drugs with similar names. You can just put them lower down that list, okay? You can separate out the strengths, just as you would do in a dispensary. You would separate out the things that are easily confused. You can block inappropriate intervals for high-risk medicines. That's been done with methotrexate. It's virtually impossible now, is my understanding, to prescribe it anything other than weekly. And you can do that for the other drugs. Why not do that for alendronate? There would never be a circumstance where 70 milligrams of alendronate would be anything other than weekly, to my knowledge. So why not implement that for other high-risk medicines? Automatically inserting dosage instructions sounds like a brilliant idea, but actually one practice highlighted that there's a potential issue with this. If you have something like doxycycline, where there are two very different indications, two very different dosage schedules, you can end up giving the wrong thing. So there needs to be a bit of caution around using automatically inserted dosage instructions. And as I said earlier, make sure the interaction alerts are graded and that they have a summary there to give that little bit of extra information. In terms of repeat prescribing, I said about not accepting verbal orders because if you have someone phoning up, you can mishear them, you write it down, then you go into the patient's system and you pick it off the tick list. But if you get an email, because some surgeries use emails and email requests, you get the email in or the paper request in, you can misread the handwriting and pick the wrong thing. You can misread what it says in the email and pick the wrong thing. The best thing, which I believe was iSoft actually, is to have an online tick list for the repeat prescription requests. So nobody has to write anything down. The patient goes in, ticks it online, and then it just gets generated. And that was felt to be a big safety improvement. And having just plumped for iSoft, I'm going to plump for EMIS now with EMIS practice notes, because the practices that used EMIS practice notes found them really useful. Now these are linked to individual records for patients. So when patients requested repeat prescriptions that were not authorised, a message was put onto EMIS practice notes, sent to the GP, and you automatically had this audit trail. You never lost the paperwork, which is what the issue had been before, and you could follow it up. And it meant that when you saw this message, you were also next to the patient's record, so you could go in and double check. And the GPs felt that it just increased the chances of you checking that information properly. They also used them for all sorts of other things, like telling each other that they'd done something wrong, prescribing errors and things like that. In terms of monitoring, the computer system makes monitoring in general practice, or should make monitoring in general practice, a lot easier, because you can have screen alerts to remind you to monitor patients. You can search the computer systems to identify patients who need monitoring, and you can set up regular audits to make sure you're not missing people. But you can also have computerized templates for chronic disease management so that it prompts you to do your monitoring. And you can have electronic specialist correspondence as well, so that it's just emailed straight through. You don't have that delay of typing stuff up, getting it in the post, getting lost in the post, having to re-request the letter in the first place. But there is an issue, again, around if it's electronic, you're having to switch screens to look at it, and a problem with processing that information. And a lot of the GPs that got electronic letters, ironically, either waited till the paper letter came through or printed it back out and worked from a paper version anyway. So, on to the Pincer trial, where there is some concrete evidence for the defence here. Okay, so the Pincer trial recruited 72 general practices around the country. And we randomised them to either have simple feedback, which involved us auditing the practice system for 10 different types of hazardous medicines management, so prescribing problems and monitoring problems. And we gave the practices in the simple feedback group, we gave them the results of those audits, and we gave them some evidence-based summaries to back it up. And then in our pharmacist intervention, the pharmacists went in and they gave them the information and they worked in the practices. Okay. So we ran these GP computer searches. The pharmacist goes in and has this sort of hour-long meeting where they present the results of these audits. They use the principles of educational outreach, which is where you're teaching people effectively. You're picking out key messages. It's what drug reps do to you all the time. Okay? And you use root cause analysis to try and pick out what's been causing these problems in the practice. And you work with the staff in those practices to develop solutions. And at the end of your meeting, you have an action plan. And instead of just leaving it to the GPs to do it themselves, you plant your pharmacist in there for 12 weeks, 2 days a week, to set up new systems, review all of those patients that were identified, and to recommend interventions, much as you would do in a hospital if you came across a prescription that was wrong. But this isn't done in general practice as standard, okay? So, what did we find? Well, if you just give those summaries to the general practices, not a lot happens at all. Okay? If you get a pharmacist to sort it out, you see a 29% reduction in prescribing errors and a 44% reduction in monitoring errors at 6 months. And that's still significant at 12 months. So what's important here is it's not just about changing individual patients' records, it's about setting up systems that propagate those safety defences further into the future and protect new patients from errors as well. So finally, people and computers, are they error-producing or defensive? Well, they're both, obviously. And it's a lot about how people interact with the computers that makes a difference as well. Okay. Thank you.